Welcome back to Mastering Medical, part 2 of our Hematology series, Bleeding and Clotting. We go from low platelets to high platelets to factor bleeding to the microangiopathies and finally the hypercoagulable states. For each one, a single finding makes the call. Let's go. We start with low platelets. Immune thrombocytopenia and thrombotic thrombocytopenic purpura both drop the platelet count. The smear and the rest of the blood counts tell them apart. Immune thrombocytopenia (ITP) is an isolated platelet problem. Platelets are low, but the hemoglobin is normal. The smear shows no schistocytes, and the coagulation tests are normal. In kids, it often follows a viral illness. In adults, it is autoimmune. Thrombotic thrombocytopenic purpura (TTP) is a microangiopathy. Low platelets PLS a microangiopathic hemolytic anemia, so you get schistocytes, a high LDH, neurologic or renal findings, and a normal PT and PTT from low activity of a von Willebrand factor cleaving enzyme. So isolated low platelets with a clean smear is ITP, while low platelets with schistocytes is TTP, and TTP is an emergency that needs plasma exchange. Now the opposite problem, the platelets are too high. Is this a clonal bone marrow neoplasm or a reaction to something else in the body? Essential thrombocythemia is a clonal myeloproliferative neoplasm. The marrow overproduces platelets on its own, driven by a JK2 CALR or MPL mutation, with large atypical megakaryocytes. Patients can clot, bleed, or get erythromelalgia, that burning redness of the hands and feet. Reactive thrombocytosis is a secondary response with no clonal marker triggered by infection, inflammation, iron deficiency, surgery, trauma, or loss of the spleen. So a persistent, very high platelet count with a clonal mutation and thrombotic symptoms is essential thrombocythemia, while a clear trigger and no mutation is reactive. On to bleeding. The pattern of bleeding points you to the defect. Are we dealing with deep bleeding into joints or mucosal bleeding from the gums and nose? Hemophilia is a clotting factor problem. Low factor 8 in hemophilia A or factor 9 in hemophilia B, both X-linked, so it shows up in boys with deep bleeding, classically hemarthrosis into the knees and elbows, and delayed bleeding after trauma. The PTT is prolonged, but the PT and the platelet count are normal. Von Willebrand disease is a platelet adhesion problem and the most common inherited bleeding disorder. It causes mucosal bleeding, nosebleeds, and heavy periods with abnormal platelet function testing and low von Willebrand factor activity. So deep joint bleeds with a long PTT is hemophilia, and mucosal bleeding is von Willebrand disease. Now the microangiopathies. All three give you schistocytes and low platelets. The difference is the organ hit and the coagulation panel. Hemolytic uremic syndrome, HUS, hits the kidneys. A microangiopathic hemolytic anemia with low platelets and acute kidney injury, classically in a child after bloody diarrhea from a Shiga toxin producing E. coli, and the coagulation studies are normal. TTP also keeps coagulation studies normal but leans neurologic. The tiebreaker against both is DIC. In DIC, the clotting cascade is actually consumed, so the PT and PTT are prolonged, fibrinogen is low, and the D-dimer is high, usually with a trigger like sepsis or an obstetric emergency. So diarrhea plus kidney failure is HUS, neurologic signs with normal coags is TTP, and abnormal coags with a low fibrinogen is DIC. Both of these drop platelets in a hospitalized patient. One is timed to heparin and causes clots. The other consumes the clotting factors. Heparin-induced thrombocytopenia, HIT, is an immune reaction to heparin. About 5 to 10 days after heparin starts, antibodies against platelet factor 4 activate platelets. So the count falls by more than half and the patient paradoxically clots rather than bleeds, while the coagulation tests stay normal. DIC is consumption. A systemic trigger like sepsis, trauma, an obstetric catastrophe, or malignancy activates and uses up the clotting factors. So the PT and PTT are prolonged, fibrinogen is low, the D-dimer is high, and the patient both bleeds and clots. So a heparin-timed platelet drop with new thrombosis and normal coags is HIT, while a low fibrinogen with abnormal coags is DIC. Last pair, the hypercoagulable states. A patient with recurrent clots. Is this an inherited genetic defect or an acquired antibody disease? Inherited thrombophilias are genetic. Factor V Leiden is the most common, followed by the prothrombin gene mutation and deficiencies of protein C, protein S, or antithrombin. Expect a family history and venous clots, sometimes triggered by estrogen. And factor V Leiden classically shows activated protein C resistance. Antiphospholipid syndrome is acquired and autoimmune. It causes both arterial and venous clots plus pregnancy loss, with antibodies like the lupus anticoagulant, anticardiolipin, and anti-beta-2 glycoprotein. A classic clue is a paradoxically prolonged PTT that does not correct with mixing, so a family history with activated protein C resistance is inherited thrombophilia, while clots plus pregnancy loss with antiphospholipid antibodies is antiphospholipid syndrome. Let's lock it in. Low platelets, isolated is ITP, with schistocytes is TTP. High platelets, a clonal JAK2 mutation is essential thrombocythemia. A trigger with no mutation is reactive. Bleeding, deep joint bleeds with a long PTT is hemophilia. Mucosal bleeding is von Willebrand disease. Microangiopathy, diarrhea in kidneys is HUS. Neurologic signs with normal coags is TTP. Abnormal coags with a low fibrinogen is DIC. A heparin-timed platelet drop with new clots is HIT. And recurrent clots with a family history point to inherited thrombophilia, while clots with pregnancy loss and antibodies point to antiphospholipid syndrome. That is part 2. Part 3 takes on the leukemias and marrow failure. See you there.